I've seen women lose 100 pounds like that, taking implants out. I mean, it's pretty unbelievable. And that's an extreme story, but most women lose, I would say, like anywhere from 10 to 30 to 40 pounds just from explanting surgery and from the explants.
Dr. Landon Pryor, you're not just a board-certified, awesome plastic surgeon that's really paving the way in a lot of the psychological aspects, the autoimmune aspects of plastic surgery, but you're also a good friend, and so it's awesome to have you here.
It's awesome to be here again. We did this back in 2017, so it's great to be here again with you, Thomas.
Yeah, man. I want to dive right into sort of, at the risk of sounding gimmicky, sort of plastic surgery disasters, but not just talking about, kind of the going down to Guatemala and getting butchered, but being more so.
Yeah, Guatemala is not where you want to probably go for high quality plastic surgery.
But I want to go, deeper, no pun intended, into some of the disasters that can happen. And obviously plastic surgery is not all bad. It's not all good. There's this massive in between. And, let's maybe start with sort of the psychological aspect of, what's maybe driving someone to change their body in the first place.
I put a link down below for a place where I shop for a lot of my groceries, including things like paprika, all my spices, things like that. It's called Thrive Market. That's a 30% off discount link. So that 30% off discount link gets you your entire grocery order at that discount, plus a $60 free gift when you use that link down below. So they specialize in getting cleanly sourced products. So the food that they have there, the spices they have there, there's no hidden nasty stuff in it. It's not like when you go to a regular grocery store and there's going to be random, natural flavors in your paprika. It's like, who wants that, right? The point is they are really trying to make good, healthy food accessible to all people. So that link is down below, 30% off, plus a free gift. So whole grocery order, 30% off in that top line of the description.
Yeah, that's a really good question. I was on the Pampa podcast a few weeks ago, and he asked me, what's, certain things that are quote unquote bad about plastic surgery. And you have to kind of take a step back and think about, what it is that we're trying to accomplish as plastic surgeons. And obviously everything we do, whether it's plastic surgery or what you do, if you're an ethical person, you want to make sure that you're doing right by other people. And so in plastic surgery, that's no different. And it all comes back to, in my opinion, making sure that you're setting expectations and patients are able to make an informed decision. That's called informed consent in the medical industry. And so what we do in plastic surgery is, we take somebody, and plastic surgery is kind of a broad category. Obviously, it's got, the aesthetic stuff that everybody knows about. So that means that it's not quote unquote medically necessary. It's something that somebody's doing to feel better, improve their self-confidence, change their form. So plastic surgery is changing form and function. So on the aesthetic side, we're changing form. And then there's a whole other category of reconstructive plastic surgery that, the medical institutions consider quote unquote medically necessary, which typically means insurance is going to cover it and you're improving function. And that could be, fixing somebody after an accident, fixing somebody after some kind of cancer surgery. It's a very broad field. So, to go back to answer your question, plastic surgery disasters, I think what we hear about most is, the attention it gets in traditional media and social media when somebody goes in for, an aesthetic procedure that's been botched, right? I mean, Paul Nassif, I know him, obviously that's the focus of his show. People that have, wanted to go to the extreme for one reason or another and have surgeries to help them, continue to feel better about themselves. And I think as plastic surgeons, and I think most of my colleagues would agree with me, there's definitely kind of a spectrum that is considered appropriate. And, that as it relates both to, the amount of surgery that we're doing, the type of surgery that we're doing, and I'm talking primarily about aesthetic plastic surgery. So, with that, I mean, we want to be able to help patients. We want to be able to help somebody that feels that they could have a higher quality of life if they fix this perceived imperfection that they have. That could be excess skin, that could be prominent ears, that could be a big nose, that could be a small jaw. I mean, all of these things, obviously, that could be wrinkles, it could be, hair loss. I mean, there's lots of things we do in the aesthetic industry that people, for whatever reason, we can kind of go down that rabbit hole about, whether it's appropriate to judge yourself based on your appearance. I mean, that's a whole nother discussion and social media and everything else. And so, we can probably get to that. But, for whatever reason, people are very judgmental of their own appearance. Most of this type of thing starts at an early age, usually gets exacerbated. It's worse now with social media, with everybody with selfies and photos and seeing what they look like and seeing themselves online and, comparing themselves to their peers or their friends. And, always kind of keeping up with the Joneses type of thing, wanting to be the prettiest, wanting to have the most wealth and look like the most successful. So, as a plastic surgeon, I think it's our job to make sure that we're doing right by the patient. So most of the patients that I see, and I would say most of the patients that seek plastic surgery have, realistic goals. There's a perceived imperfection. Like I said, maybe it's their nose, maybe it's their loose skin after having had a baby, maybe there's, other aesthetic concerns that they have, small breasts, large breasts, whatever it is. And if we think as plastic surgeons that we've got the appropriate skill set to deliver an outcome that's going to make the patients happy, that's really the nature of plastic surgery, and that's what we're doing. Where that becomes problematic is when it's being done purely for incentive, for monetary incentive, right? So if I know that I can't help somebody, like, what the patient's asking me to achieve is not going to make them happy. And that might be because they don't have a realistic outcome in mind. It might be because, based on my experience, I see the quote unquote red flags. I know that I'm not going to be able to get an outcome where this patient is going to be happy. I don't particularly get strange requests, but there are strange requests. You've seen this stuff online, people that want to look like animals and other storybook characters and, extreme plastic surgery overdone. And, that I would say that's the minority of patients that choose to get aesthetic plastic surgery. But, I think our job ethically as physicians and as surgeons is to deliver on what, the patients are asking for, as long as we can do it in a way that's ethical. And, we believe that based on our skill set, we can get the patients to an outcome that they'll be happy with. And so those are the expectations that we set with the patient from the onset. And, it wouldn't be unusual for myself or other experienced plastic surgeons if they meet a patient that they don't think they can realistically achieve their goals or their outcomes. It's not good for the surgeon. Obviously, there's risks involved. We don't want upset patients. We don't want patients that don't feel like they got what they paid for. We just tell the patients we don't think we can meet your expectations. And that's probably the easiest way to avoid those types of problems where, you commit to doing a surgery and then for whatever reason, you didn't align on expectations before surgery, or the patient just wasn't a good candidate, meaning, regardless of what they thought, this surgery was never going to make them happy. It wasn't going to change who they are. It wasn't going to change how they feel about themselves. There's actually a book called Psychocybernetics I'd encourage any of your viewers to, look into that. It was written by a plastic surgeon in the 50s by the name of Malcolm Maltz. And basically what he identified at that time, and this has been replicated many times by plastic surgeons and others, is that unless people actually change that kind of root cause analysis of how they're perceiving themselves, and this goes into mindfulness and spirituality and other things I know we like to jam on, but as it relates to plastic surgery, if you choose the wrong patient for surgery and they don't have realistic expectations and they're going to continue to be unhappy with their appearance, then it's going to be a dysfunctional relationship, and those are the patients that you really don't want to operate on.
Are there any sort of signs that patients give you ahead of time that say, like, maybe outside of the extremes, like in your experience, subtleties that say, hey, this is a deeper psychological reason? Like, are there things that you've learned to say, wait a minute, like you said something that made me think that this, maybe doing this for the wrong reason? Yeah.
So, the term that gets thrown around a lot in the industry is body dysmorphic disorder. You've probably heard that. And so basically what that means is, the perceived impact of a visual flaw is out of proportion to what it actually is from the patient's perspective, meaning somebody comes in and they say, I can't live. I've got this line here. It's so debilitating. I mean, I look terrible. I'm hideous. Like, I can't get a job. I can't get a date. It doesn't be a line. It could be a big nose, or it could be a bad neck or whatever. So, basically, the perceived impact of that that flaw or that imperfection, and their ability to lead a, quality of life is a pretty big indicator that, they may have this body dysmorphic disorder. Other things would be, patients coming in and having had multiple prior plastic surgeries, usually by multiple physicians, that, they're unhappy with the results. So, you see these patterns develop. Yeah. They've had 3 prior surgeries. They demonize, the prior surgeons that have done the surgeries. Their expectations weren't met. Maybe they think you're the best thing since sliced bread, and all these other surgeons that they've talked to are, the worst. This kind of like borderline splitting personality. A lot of this stuff goes into, what we see in our patients, and helps, experienced plastic surgeons decide whether these patients are appropriate for surgery.
So it's almost as though, you have to become part psychologist in this case.
It is. And that's the part that I think isn't really taught, so much, and obviously not in medical school. Medical school, you're, learning the basics, you're learning anatomy and physiology and pathophysiology and microbiology and pharmacology and all the basics that you need to be able to be a physician. Then you go through residency and fellowship, and that's all, for the most part, technical training, right? Like, how do you do a rhinoplasty? What are the steps involved? And so that residency does a really good job teaching how to do plastic surgery. But in my experience, what you really need, the experience in practice doing is engaging with patients and understanding, what it is that you need to say and do to make sure that you and the patient are aligned on expectations. And, like you said, a lot of that is just experience. And, I can talk to somebody now and know within minutes whether or not this is somebody that's going to be a good candidate for what they're asking for.
It's almost as though there needs to be a post integration, and almost more importantly, even like a pre-integration. I don't know what that word would be, but where it's like, you're really
like an assessment, like you're
assessment,
almost,
so that you're not getting this dopaminergic hit after every surgery, right? Like, it's just like, because you're just gonna, just like, if it becomes that much of a almost manic cycle of surgeries, right? Like, for lack of a better term,
it can be an addiction,
yeah.
Right? Just like anything else. I actually have good friends that are addicted to plastic surgery, yeah, and to aesthetic services, and that's not healthy either. So. The ideal patient is, and this is why I love, rhinoplasty surgery, because, while it is one of the more technically challenging surgeries, I think that those patients, in my experience, are some of the happiest after surgery, mm-hmm, and some of the most realistic, because they have a real specific anatomic concern about their nose. It's usually something that's bothered them for a long time. They've had obviously bullying or just felt insecurity about their appearance for a long time. And then you fix it, and it's not hard to do. For an experienced plastic surgeon to get an outcome that the patients are happy with. And, they're happy with the result. They feel more confident. You can see them the next day, like literally they feel like a new person, and they go on and lead healthier, more productive lives. I can say that as somebody that's had my nose done more than once. But so, I'm obviously also a patient as well as a surgeon, so I understand it from both perspectives. And I know it can be, challenging from a surgeon's perspective to try to align on expectations, but that's really the best way to avoid having problems after surgery. It's kind of like, I don't know if you say this or I've heard other people say it, but like really the decision about what kind of food you're going to eat should come before it's in your house. Yeah. Like when you're in the grocery store, like that's where you make the decision. Like, I'm going to put this in my cart or I'm not. Like once it's in your house, it's too late. Yeah. And it's, kind of like the same thing with plastic surgery. Like, that initial consultative process to me, somebody that's experienced, I'm not doing this to make a living. I don't need to do plastic surgery and trade time for dollars to, have a lifestyle that I'm happy with. So, at this point in my career, I want to do it to be able to really solve a problem for a patient that I think I can help.
What are some of these other, more long-term problems that can occur? One of the areas of, expertise that you're kind of paving a lot of the way with is BII, where you essentially are having, breast implant illness is what that stands for, but mm-hmm, it opens up its category of just all kinds of different discussions, right? Like what is happening and what are symptoms that people are feeling, and what is BII? Let's just start there.
Yeah, and it's scary that we're even having this discussion, to be honest. I literally was just talking to your camera guy, and he's like, I've never heard of that. And I was like, you're the GOAT, right? So you've been doing this for a long time, not specifically BII, but inflammation, right? Like everybody knows you're the inflammation guy. You've been doing this for decades. You know what you're talking about. And it's still not something that's commonly discussed. We're starting to get, more and more traction in the industry. But to answer your question, so breast implant illness, or BII, is a term that's used to describe a constellation of symptoms. And those symptoms can be wide-ranging. They're usually nonspecific. A lot of neurotoxic types of symptoms, so brain fog, fatigue, insomnia, post-exertional malaise, arthralgia, rash, weight fluctuations, other neurologic symptoms, tinnitus or ringing in the ears. There's a huge spectrum of symptoms that we see. Pain, joint pain, I think I mentioned hair loss. And so this kind of nonspecific constellation of symptoms could be a number of things, right? So it also goes by ASIA syndrome, autoimmune inflammatory syndrome induced by adjuvants. This has been well described. So, we like to label things as physicians, right? So, these patients have these symptoms, so they're diagnosed with this condition. And as a medical doctor, I've been trained that, in order to treat this condition, we give medication, right? We give immunosuppressive medication, we give anti-inflammatory medication, we suppress the symptoms. And so kind of going back to my answer, it's a constellation of symptoms that could be a number of things. And I've been through my own kind of health issues, as you know. And so had I had breast implants, this would be called breast implant illness. Now, because I didn't have breast implant illness, it was put into a whole nother, potential category of illness that a lot of our patients are also diagnosed with, possibly Lyme, possibly mold exposure, possibly, anxiety, depression, all of these kind of nonspecific inflammatory symptoms that patients develop, usually very insidiously, meaning, quickly, there's some environmental insult in their life or some big stressor in their life, and all of a sudden their symptoms develop. And they may have had implants for, a couple months or a couple years or even a couple decades. And all of a sudden, they start developing symptoms. So what kind of defines breast implant illness is you've got this constellation of symptoms, but the important thing is those symptoms improve or completely dissipate after removal of the insult, of the implants. And this has been shown study after study after study. This is what differentiates BII from some of these other inflammatory conditions. I mean, there's no quick fix for, multiple sclerosis caused by, other autoimmunologic conditions within the body. There's no quick solution for rheumatoid arthritis and some of these other conditions, other rheumatologic conditions that these patients are diagnosed with. With BII, it's a diagnosis of exclusion, meaning, we can't definitively tell patients prior to surgery, like, you have BII, and that's why we're going to take your implants out. It's a clinical judgment. We take a neurotoxic questionnaire. We understand what their symptoms are. We try to exclude other possible causes. We set appropriate expectations. We go through an informed consent process. And then if the patient goes through surgery, gets their implants out appropriately, which we can talk about what that actually means, and their symptoms improve or resolve, now the surgery's been both diagnostic and therapeutic. Therapeutic in the sense that we've taken the implants out and improved their symptoms, and diagnostic meaning, okay, now I think we can confirm the diagnosis that it was BII because we removed the challenge. It's called de-challenge. We removed the implants and patients got better. Clearly cause and effect. If you got sick and we took your implants out and you didn't get better, then you most likely didn't have breast implant illness.
So it's probably hard to get mechanistic with this because it's I guess a little bit of a gray area. But in your expert opinion and your research, what do you think is mechanistically going on? Is it just the fact that you've got silicone in your body and your body's rejecting it and it's triggering sort of an ongoing chronic immune response?
I think yes and no. I think it is a chronic immune response, like you said, chronic inflammation. And, we have known for a long time that chronic inflammation in the body causes these symptoms. You know that better than anybody. But now it's chronic inflammation related to these implants. And it doesn't matter whether it's a saline implant, which by the way is, inside a silicone elastomer shell, or a silicone implant. Doesn't matter whether it's smooth or textured. That's a whole nother discussion. But what ends up happening is, and this, it's not rocket science. You don't need a plastic surgeon to tell you this. You put something foreign in the body's going to respond to it. Now, the typical teaching is that the implants are quote unquote inert, meaning that they don't stimulate a biologic response within the body that causes symptoms. But what we see time and time again, and this isn't necessarily unique to breast implants, this is also true of other types of implants in the body. There's a great article by Schoenfeld and Talbert who described dysphagia syndrome originally in 2011, and then they republished new findings in 2023. We could probably put a link in the episode if people want to reference that. But basically what they found is, putting these foreign bodies within the body, foreign material causes the body to recognize it as foreign like you would expect. That's not something that people don't already understand. But what ends up happening is people that are genetically predisposed to having inflammatory conditions have a higher susceptibility to developing breast implant illness. So what happens is you put the implants in, the body recognizes it as foreign. It forms this capsule around the implant, which is basically like scar tissue or an inflammatory rind around the capsule to wall it off and prevent that foreign material from going elsewhere in the body, or at least that's what it's designed to do. But what ends up happening is in certain susceptible individuals, that inflammatory process doesn't turn off, kind of like why some patients form a keloid and others don't. Yeah. It's like a lot of it has to do with genetic predisposition. But what ends up happening is, they over time develop more and more of these inflammatory mediators in and around the breast. That can lead to other things like capsular contracture. That's been well defined. It can lead to the development of biofilms, which is another potential mechanism for the development of BII. And eventually, if the inflammation is around long enough, just like in other areas of the body that you talk about, you can develop cancer. You can actually develop a cancer within the capsule called anaplastic large cell lymphoma, which is a lymphoma that's actually derived from the breast implants in the capsules around the implants from chronic inflammation. So that's a whole nother kind of discussion about breast implants. That's not really what we're talking about today with breast implant illness, but the point is it all comes down to the body responding to an invader, something that it doesn't recognize itself, and starting this inflammatory cascade that eventually leads to the development of symptoms in both, I said genetically susceptible, that's part of it, and also what I would call environmentally susceptible. So that kind of leads into the second part of the discussion, which is, what are the triggers that cause people to develop BII? And I think, I went through the PAMPA program myself. I'm a big advocate of his. I think he's got a really great message, and, he really understands, cellular detox. And basically he talks about the stressors that cause these dysfunctional genes to turn on and cause dysregulation. So physical, emotional, and chemical stressors. It can be a combination of those, but usually it's not just one specific thing. The breast implants, in my opinion, they accelerate that process. It's like one more inflammatory process within the body that accelerates these symptoms. But, it could also be that somebody had these, lives in a moldy home, or they've had exposure to other biotoxins in their, in their work environments, or other chemical toxins in their household chemicals and in their, work environment. So I think it all kind of comes together, and BII is specific to breast implants, but it's just one more thing that kind of piles on to this already toxic environment that we're living in.
So when someone comes to you with, are they usually pretty well educated on BII in the first place, or are they actually coming to you being like, I haven't felt the same since this, or like what is sort of the patient cycle like here,
yeah.
Right? Like, I'm sure as someone like my wife has suffered with autoimmune issues, I'm very familiar with autoimmune issues, and a lot of times it's like
it's challenging.
It's challenging.
Yeah, in the healthcare system and figure it out. And so the typical scenario that we see, by the time patients are ready to be diagnosed with BII and actually go through an explant surgery, they've already gotten a lot of information about it. Typically what happens is, they're not informed about BII as a possibility when they get their implants. That's problem number one. We're trying to advocate for informed consent. Not that implants come off the market, but that patients that get implants understand what BII is, just like other risks of surgery, rupture, capsular contracture, breast implant illness, so that if they do develop symptoms, I still think getting breast implants should be up to the patient. There's obviously benefits to getting implants for certain patients, and we can talk about that. It makes them feel more confident, makes them feel more comfortable in their body, it makes them feel more attractive. Those are all quote unquote good things, right? But you got to balance that against the potential risks. And so what we're trying to advocate for is making sure that, plastic surgeons are informing their patients about this possibility at the time of implantation, so that if they do develop symptoms 2, 5, 10 years down the road, they say, that's interesting. I didn't have these symptoms before. I have them now. I wonder if this could be related to my implants. Because it's still not very well recognized in traditional medical circles. So what happens is patients go to, their primary care doctor and they run a bunch of lab work, and generally it all comes back normal because their lab work actually hasn't started changing yet, but they still have the symptoms in their body. And many times they'll go to specialists, they'll go to rheumatologists and endocrinologists and neurologists and get like I did, all kinds of, diagnostic tests done. And, it's generally inconclusive, and they'll be given some kind of what we call waste basket diagnosis, meaning, we don't know what it is, but we're going to call this to be, chronic fatigue syndrome or fibromyalgia or one of these other chronic inflammatory conditions. And so, usually patients become very desperate, especially the educated ones, the people that have the resources to understand this and get online and figure out, something's not right. I understand my doctors are telling me, I'm fine. I'm just getting older. I'm perimenopausal. I'm depressed. I got marital issues. We hear all of that stuff. And it's very invalidating for these patients because this goes on sometimes for years. And they can't find solutions until, just in the last, I would say 5 to 10 years, people are becoming more outspoken about breast implant illness, people like myself and others. And then there's a lot of these social media groups now that obviously help advocate for and support women with breast implant illness. So if you just Google around now, I don't feel good, these are my symptoms, BII groups will pop up. And then they get into these groups, and then they can obviously communicate with other women that have had similar experiences, and they learn about BII. And there's a lot of resources online out there now about that. So usually that, and then there's kind of a group of surgeons, because there's still not, as many surgeons taking implants out or explanting as there are putting implants in. So, they'll identify somebody that has experience doing these kinds of surgeries, and there's groups that actually specifically identify surgeons based on experience and reputation. And then, they'll end up going to somebody's office. And so by that point, usually what we see is patients are coming in. They're generally not happy to be there. This is kind of a last resort for them. They know that they don't feel well, but they've come to the realization that for them to feel better, they may need to get their implants out. And that goes back to what we talked about earlier. Patients don't want to get their implants out. They don't like the aesthetics of not having implants. That's why they got implants to begin with. They don't like the emotions of not having implants. So it's a challenging surgery because we have to set really clear expectations with patients and just make sure they understand that, just like getting implants in, this is a lifelong commitment. And, the goal of this surgery is to get them to feel better, right? That's really the primary goal. It's really more, and why I like doing it like a reconstructive surgery. We're actually solving a functional issue. It's not just about aesthetics. Yes, we want the breast to look as good as possible after surgery, but, it's really being done to help patients feel better. So that's kind of the scene that we see when patients come into the office. Most of them have, had resources that they've looked into online. They've had typically friends or family members they've talked to about breast implant illness, and they're coming in pretty educated about what it is they need to do to try to feel better.
So, the thing that pops out for me is you likened it to, kind of mold exposure in some ways. And that's really interesting because BII is unique in that to actually remove the toxin, so to speak, you actually have to, undergo a surgery. So it's like where, I've learned as someone that's lived in a moldy house, and I've understand that world that sucks. And step one is you have to get out of the moldy house, right? There's all these things when you're in that house that you can do to mitigate the secondary symptoms, right? but it's very difficult to triangulate and ultimately get down to what the root issue is, even if you already know it's mold, right? Like, okay, so what mast cell activation is going on here that's causing this? And then, there's an intersect with histamines and all kinds of other things where it's like, okay, I'm in this moldy home. I don't feel great. There's something that my baseline is just crap now compared to before, but it's not like debilitating. But then how come when I have, a lot of times with mold, it's mycotoxin-rich foods. So it's going to be if they already have a mold issue and then they have grains, right? Like it's just, and this is where mainstream and even, I will even say like content online really invalidates people. Oh, there's nothing wrong with rice. There's nothing. Okay, maybe not for the normal person, but when there's this underlying inflammatory condition or toxic exposure to mold or some of these other things, then most certainly that can exist, because then all you need is just a little bit more of a stimulus to kick you off. Yep. So it's extremely invalidating when people will be like, grains are fine, you're demonizing grains. Like BS. Like, no, some people really have an issue. But then it's like this further discussion of it's not necessarily the grains. It's the fact that, okay, they've got this prior underlying condition.
It's the totality of the circumstances. Yeah. And it's the same thing with BII. And we get that question all the time. Like, what are the chances I'm going to develop BII if I get implants? Or why, does this person have implants and they feel fine and they have no symptoms and, they're happy with their implants and I'm the one that's suffering? And the answer is, it could be a lot of things. It could be like we talked about your genetics, or I know, you're very familiar, your audience familiar with epigenetics and how important that is and what factors, influence epigenetics and, how to mitigate inflammation in your body, your food, your water, your products. I mean, all of the toxins that, you talk about that contribute to this inflammatory process in the body. So, like I said, the implants are just kind of one more thing. It's kind of fuel on the fire, without getting into a lot of controversial issues. But, it's not, just because patient A has it doesn't mean patient B is going to get it. I think that it is, it is an inflammatory driver in everybody, just like certain foods are, just like toxins are in the environment. But that doesn't mean that everybody's going to respond to it with breast implant illness. Some people might have the ability because they've got better detox pathways open, their lifestyle decisions are better, they've got more functional reserves. They're able to compensate for, the additional insult from the implants, and they don't ever develop symptoms. But, me personally, I prefer to keep, foreign things out of my body. I know that it's not meant to be there. And so, I wouldn't want to get breast implants if I was a woman. And, I just think that knowing what I know, I could no longer justify putting implants in, and people ask me that all the time. I used to put implants in, when I went through residency, actually the moratorium on silicone breast implants had just ended in 2006, 2007. We were told as residents and as fellows, just like they are now, remind me, I have a funny story about that, but we were told, implants are safe, which is fine. So, we're doing what we do as plastic surgeons and we're trying to help the patients feel better. And somebody comes in and says, I'm not happy with my breast. I want them to be bigger. Okay, we'll give you bigger breasts and we'll give you breast implants. No problem. Don't think about it twice. But, now knowing what I know with, not only the scientific literature about breast implant illness and about breast implants, but, the clinical evidence that I've seen firsthand. I can't deny the fact that it's a real entity that deserves a medical diagnosis. And there's literally millions of women suffering with breast implant illness, and they have no idea why they're suffering. And to me, that's the most frustrating part of all this is just there's not enough people talking about it. Like I said on the car ride over, like as I thought about my intention for this podcast, it's like, I need to make sure that we're doing what we can to make sure that patients are aware about the potential dangers of breast implants so that they can make an informed decision. It's really unfair to these patients that, they get breast implants, they know nothing about BII, they develop symptoms, like I said, could be years later. They're not able to make the connection. Their surgeons or doctors don't make the connection, and then they're just miserable. And and it's totally avoidable, and it's just no way to live.
Yeah, and some of the stuff, like weight gain, all these things that happen after implants, right? Like there used to be a lot of people that would say, psychologically, and there could be a psychological component because there's a lot of women that after they get breast implants, they gain a bunch of weight. And some of it's psychological because maybe they've checked that box and now they feel better, so they kind of let go. When you look at inflammatory conditions and how that works and that entire cascade and the cataclysm of things that happens once you have, like, weight gain is a very realistic thing, a very common thing. And you've got women that, they could be in the age where they're, menopausal and they're going to have these changes, but a lot of times they're not, and they're confused as to why is my body changing after I've had this procedure done. And again, it's one of those things where you don't have a smoking gun to say yes, it's this, but when you start kind of adding all these things up, that's where
weight gain's a big one, and we see women. I've seen women lose 100 pounds like that taking implants out. I mean, it's pretty unbelievable. That's an extreme story, but most women lose, I would say, like anywhere from 10 to 30 to 40 pounds just from explanting surgery and from the explants. And I think that's just because we've taken the inflammation out of the body. Their immune dysregulation is improving. They're able to metabolize normally. Their mitochondrial function's returning. They're able to metabolize energy and use energy more efficiently. And so their bodies are just kind of getting back to where they were prior to getting implants. And it's, that's usually the least of their concerns because they, already don't feel well at all.
Crappy,
they feel so crappy. And that's just like, and I'm gaining weight. Okay, well, take the implants out. And then, it also, taking the implants out, or we call it removing the source, isn't the entire solution either. Mm-hmm. A lot of these patients, depending on, like I said, their predisposition, their environmental factors, their lifestyle decisions, need to do other things to reduce inflammation in their body. Just like it's no different without implants. Like, if you eat and you don't take care of your body, you don't move, you don't get fresh air, you don't get fresh water, you don't do the basics, like, you're not going to feel well. And it's obviously no different with breast implant illness. I mean, I believe that, I know that everybody is going through these detoxes and trying to get their inflammation out of the body. And I think there's validity to that. But I think, remove all of these toxins and obstacles that are preventing your body from healing. And, the body is so much more intelligent than we give it credit for. And we want to say, like, we're controlling the healing in the body. We have no clue what the body's doing, right? Yeah. Like, even if you drink your water, could you tell me, and you're an expert, like, what happens every step of the way from the time that you drink the water to when it comes out? Yeah. I mean, are you controlling that? Are you
exactly?
You're saying this cell pick up this water, this cell deliver that water. Okay, now do this chemical reaction, do that. No, your body is innately intelligent, and that's really what I enjoy about this is, just kind of getting all the interference out of the way and let your body just heal naturally.
Yeah, it's a good way to put it. It's this interference, right? And are you seeing pushback on BII in terms of, like, is there any, like, fiduciary obligation that some people have? Like, is there still a push being like, no, it's fine. Like, are you facing opposition, or is this more so just an awareness?
Yeah, I think both. Yeah. I think so. Awareness is lacking, both in, I think, in the plastic surgery industry, people at this point, and there's been plenty of publications, it's been talked about at national meetings. So I don't think there's any denying in academic plastic surgery circles that breast implant illness exists. Problem is, number one, I don't think that message has really resonated with the rest of the traditional medical industry yet. So when these patients are going to their doctors and going to their specialists and getting these tests done, nobody's thinking about BII. I mean, these patients could be getting all these tests done for all these inflammatory conditions and get put on immunosuppressive medications or being diagnosed with chronic health conditions. And they're put on these meds to, minimize the symptoms, but not at any, very rarely do patients actually come in and say, oh yeah, my integrative medicine doctor referred me because of my implants. Like, that's just not recognized yet. Yeah. So that's another big area of awareness is, in the medical community, so that even if the patients aren't aware that they have BII, that somebody else is going to pick that up. That's why we do a lot of education of medical students and residents so that, we can help raise the awareness in the medical community. And then the other, potentially controversial topic, this isn't controversial when you talk to international leaders, which I've done, look at international research, which I've done, talk with, the advocates and the patients that have been through this experience, based on now tens of thousands of patients. But, there are some proponents that would argue that, doing what we call an en bloc capsulectomy, which means taking out the implant in the capsule altogether, or even just a total capsulectomy, meaning taking all the capsule out, is potentially unnecessary. And so I don't believe that. I would say most people that really understand breast implant illness don't believe that. But if there is a point of controversy, it's probably, okay, we understand that BII exists, and we understand that taking the implants out allows patients to feel better. And I think both of those are true, kind of regardless of how you do the surgery. But the question is, what are going to give the patients the best chances of long-term success, minimize recurrence of symptoms, minimize ongoing inflammation, minimize need for reoperational surgery, which sometimes happens when the procedure is not performed correctly and the capsule's been left behind. We've seen lots of patients that have had implants removed without a capsulectomy that have persistent symptoms that have to go back for a total capsulectomy at a second stage. And kind of taking even that aside, leaving that capsule behind puts patients at risk of, leaving behind an occult or a hidden cancer like we talked about earlier today, puts patients at risk of potentially spillage of that content, especially if it's silicone, into the body cavity, which can cause all kinds of other inflammatory conditions within the body. So the goal of the en bloc procedure is, you're taking that implant out, but you're leaving this shell of capsule around the implant as you're removing it. That's actually a term that goes back to oncologic surgery, meaning you don't want to touch anything. You don't want to have the cancer touch anything else in the body. And so that's really how these surgeries are performed. And that's how I actually do those surgeries, in a very meticulous way, to make sure that, if at all possible, this implant's coming out with all the capsule attached to it, without any spillage of content, without any violation of the capsule. And, at the patient's discretion, we typically send that for pathology to make sure that they don't have any biomarkers that would indicate they have this underlying potential cancer, ALCL. Also, there's other cancers that can be hidden in the capsule, squamous cell carcinomas. That was published by the FDA not too long ago. So, there's lots of medical reasons to do the procedure that experienced explant surgeons do, which is the en bloc capsulectomy, to get the implants out, reduce the symptoms or eliminate the symptoms, and give the patients the best chance for long-term improvement.
Interesting, because I was talking with, do you know who Dr. Sean O'Mara is?
I don't know.
He's like a big, probably the leading visceral fat expert, right? Okay. And the reason I don't know anatomically if the breasts are going to be in a sealed sort of capsule away from the other potential visceral adipose tissue and the other organs. But I have a point here. But he is a huge proponent of the belief that, and I tend to agree with him. He's he's amazing. He was the presidential physician for Clinton and Bush. The dude's just top notch. His brain is amazing, and he can really pinpoint the fact that visceral fat is probably the primary metabolic dysfunction, and because of the inflammatory condition. And then he goes down even to epicardial fat, fat that actually surrounds the heart. And he's convinced, and he claims that there is not one documented autopsy report, documented peer-reviewed study, nothing, where the patient has had a heart attack and has not had epicardial fat. So he's convinced that it is a what is he called, a structural disease with myocarditis and all these things. And the reason that I say that is because visceral fat and epicardial fat, it's always a point of contention of which came first, the chicken or the egg, because it's very inflammatory fat, right? Mm-hmm. So it's a unique fat that causes a localized inflammation. That's where the discussion with this is all coming in play. The discussion I had with him recently was interesting. I'm like, okay, yes, this can cause systemic inflammation, but the real problem, especially with myocardial infarction or anything, is that you're going to have this localized inflammation that is directly coming from this epicardial fat surrounding the heart. And it's a very small amount. It doesn't take much. And it's essentially leaching inflammatory cytokines consistently into the heart, where those macrophages and foam cells can ultimately form and truly cause plaque. So it's a very strong argument that he has. And it's very convincing. So where I start to go with this is okay, do you potentially, because you have a localized area of inflammation, because there's systemic inflammation, what might manifest in the symptoms that you're describing and people might feel, but there's possibly a localized inflammation of, TNF alpha and all the various, interleukin, I guess it would be 1, interleukin 6, that's really just concentrated in that area, right? if that is the case and you formed a fat there, depending on which came first, the chicken or the egg, could you actually form a visceral type fat that's surrounding that's an inflammatory fat that's continuing to leak inflammatory cytokines systemically?
Yeah, I mean, absolutely. There's no question that the implants have this inflammatory shell. So even macroscopically, meaning with my eyes, usually I do these surgeries with what's called loops on, which are about 2.5 times magnification, but without a microscope, with just, little additional magnification, and even somebody that wasn't wearing loops would be able to see this. So you got the implant, you got the implant shell, then around the shell, you've got the capsule. Then around the capsule, you've got, typically fat, and breast tissue. But you can see, especially in patients that are significantly inflamed, that there's inflammation in this tissue. I mean, and it's really tough to describe, but once you see it, you can't unsee it. Mm-hmm. It's like very fibrous, inflammatory tissue that's outside of the capsule. It's like another layer of inflammation on top of the capsule. So I totally agree that there's inflammation in the breast as well as systemically. We see patients that have lots of localized symptoms as well. So breast pain, shortness of breath, chest pain, anxiety, racing heart, cardiopulmonary symptoms, which I also think is related to not only the mechanical effects of the implants themselves, but also just the BII in general. Interestingly, that paper I mentioned, the Schoenfeld paper on Asia syndrome, in one of their studies, they saw that patients that had a higher BMI, patients that were more overweight, actually had more improvement after removal of the implants. And so the hypothesis is these patients are already more inflamed. They're already predisposed to more inflammation because of their higher BMI. We know fat's obviously inflammatory. So their symptoms were more exacerbated and more improved by actually removing the source and taking the implants out. So I think you're spot on with that.
Yeah, I think there's a second layer that might be.
There's always more. And I wanted to make this point too, because like I just said, there's always more. There's always more to learn. There's always new data coming out. There's always new new paradigm shifts. It's happening in a lot of different industries right now. Healthcare is no different. And one of the things I love about your transparency and number one, I was thinking about this coming on this podcast. I mean, I've been following your content since like 2016. And if you're talking about it, I know you do it. I know you believe in it. Like you don't just sell a bunch of garbage. Like you don't talk about something unless it has like scientific validity and you can like actually believe in what you're doing. But I think more importantly, you're not afraid to say when you've changed your perspective. It's been 10 years since I've done this, and this is how my thought process has changed over the last 10 years, or this is how I do this differently. These are things that I would do differently, compared to 10 years ago. I mean, you release videos like that all the time. And I think that's really important. We're starting to see certain industries acknowledge that, okay, like the information we were using before is outdated. Like it's probably like 20, 30 years old. Like it's time to like upgrade and like use more information that is relevant in, today's population. And they're coming out and saying, okay, we can do better. We're going to remove these food dyes or, do whatever. We're going to acknowledge that there's, probably ways to do this that is better than what we've done in the past. And so I think as plastic surgeons, we need to also be willing to say, okay, breast implants have been around since the 60s. A lot of this data, a lot of the, information that we're taught is probably outdated. There's like way too much scientific validation now to try to say that BII is not a legitimate diagnosis. And we just got to do better. I mean, it's not that hard to just come out and say, the information is better. I mean, the science has evolved a lot. Science is always changing. That's kind of the nature of science, right? And as physicians and as surgeons, we just have to do better for our patients.
Yeah. No, I think at the end of the day, sometimes it does fall on the physician to do their research too. We've got these sort of Newtonian physics that like most of physicians are following, and they're all.
That's what we're taught. Yeah. That's what's taught in the medical school. I mean, I probably don't want to get into quantum biology on this.
I don't want to get you in trouble
in this conversation. But yeah, I mean, the Newtonian physics. I mean, that's how we're taught in medical school. That's how all of the pharmaceutical, industry is designed to, treat symptoms with these, chemicals that work with those types of, physics in mind. But, like we've said, there's a lot more there. And I just think as physicians, we want to be open-minded to the possibility that as, we learn more about health and disease, that we're doing everything we can to try to promote health.
Yeah. I mean, without saying too much, though, I mean, I'll be the one that says it, so you don't have to, put your license in jeopardy. But from the quantum side, really, like we talked a little bit about, like there's this whole other side of how are these implants affecting energy flow, right? Like that's a very real thing. And even if we just talk about like not even necessarily the magical energy that you have to like really like get deep into that rabbit hole to think about, but even just the basic like frequencies from the earth, like when you're grounding and things that like, how is this stuff moving through your body? How are these hertz actually affected? Which I think there's emerging evidence on, especially when it comes down to inflammatory conditions, right? It's like the body's going to respond differently if there's not this proper resonance within the body and the cohesiveness. So it's like anytime there's something foreign in your body, no matter what that is, there's probably pretty solid evidence that is disrupting a certain, and we're not even getting into the Eastern medicine side talking about meridians here. We're talking about just flat out simple skin voltage and vagal tone and all these things, right?
Yeah, and generally the BII patient population, by the time they learn about BII, especially when they go through explant surgery and reconstruction, like they're very receptive to understanding kind of new science paradigms and perspectives. And so hopefully this will resonate with your audience. But yeah, I totally agree. We just need to continue to, push the paradigm, so that we use the best information. And now with, resources like YouTube and the internet and ChatGPT or whatever AI technology you like to use. I mean, there's no paucity of information. The information is there. We just have to apply it.
No, I'm totally with you. And end on one more thing is that, then there's the whole post-operative piece with diet, nutrition to be able to kind of help your body. There's these things where, yes, your body knows how to recover and how to heal. That's the amazing thing about the body. But it's just, once again, it's like when you come back to that mold analogy, you remove someone from a moldy environment. That is by far the biggest thing you can do. And that is step one. But then there is sort of this element of, okay, well, how do you get your body back to baseline? What do you, and it's not usually an element of what is additive. It's much more about how do you recalibrate back to baseline and take out, right?
Take out what's not serving you. And that's true for everything. A lot of these patients, I hear this all the time, and it's really heartbreaking because there's a lot of guilt and shame. We can talk about kind of the emotional impact of implants and getting them in and taking them out. But we hear a lot of patients talk about, I wish I would have known differently, or I wish I would have listened to my mom, or I wish I wouldn't have gotten these implants, or, I've been sick for so long and, half my life is gone. And a lot of these kind of regret types of things. And I think what, we try to communicate to patients is, you got to take something positive away from this. By continuing to beat yourself up over what, from your perspective, should have happened differently isn't healthy either. And that's not going to help you recover. I mean, we have to look at this as an opportunity for growth. And so kind of regardless of what your religious beliefs are or what, you think happens after we die, these are all opportunities for self-reflection, for growth, for education, for patients to say like, okay, like I went through this, but what positive came out of it for me? What have I learned? Who has come into my life or come out of my life because of this situation? How can I pass this along? And that's really one of the things that has helped the explant movement grow is these women just wanting to help each other. And that's, really what has kind of fueled my fire to really become more vocal about BII, having been through my own health issues. It's like, people have been through that. And now they're saying, okay, like I need to find purpose from this pain. Pampa calls that pain to purpose, to promise. But, so I went through this pain. There's got to be a purpose. My promise is going to be, I'm going to, talk about it. I'm going to advocate for it. I mean, most of our explant advocates have all been patients. They've been through it themselves. My primary advocate, Laura Bowden, went through this in the 90s. When no one was talking about BII. And she's committed her whole life to empowering and teaching women about breast implant illness so that we don't have to see women suffer unnecessarily.
Yeah. No, I'm with you, man. Well, where can everyone learn more about this and where can everyone find you?
So we have a whole separate site dedicated to patients that are looking to get resources about BII. So it's both the site for patients that are looking to potentially be explanted, but also patients that want to just get information. And then we, have our advocates. I have an office down in Palm Beach in Florida where we do explant surgery, and then one in Rockford outside Chicago. And so the website for that is BIIcentersofexcellence.com. And we've got great advocates, great team. We got lots of experience doing these types of surgeries. I have utmost confidence in our team's ability, to work with these patients, to identify patients that are appropriate candidates for surgery, figure out, what it's going to take to get them feeling better. I would say our, average improvement is, almost 100%. I wouldn't say all patients get better all the time. I mean, there's definitely some outliers. But I would say the vast majority, probably 90+% of patients get at least 80% better, sometimes 100% better. And so, I just think that if you're thinking about the possibility of having breast implant illness and thinking about being explanted, it's worth at least reaching out, understanding more about the process and seeing if you're a good candidate. Or, if your audience is listening and they're thinking about getting breast implants and this is the first time you've heard about BII, happy to talk with patients about options, even if it's not through one of our centers. There's people all over the country that do this kind of stuff, but, there are options for volume augmentation and improving the shape of the breast without using an implant. There's obviously a mastopexy or a lift, which can be done to tighten up the skin. You can do autologous reconstruction like fat transfer, meaning using your body's own cells and own tissue to enhance the shape and the size of the breast without an implant. So there's options for patients that want bigger breasts for whatever reason. Like I said, probably outside the scope of this discussion, but if there's anything that we can do to help patients to just get more information or help feel better, we're there for them.
Right on, man. Well, thanks, brother.
Yeah, thank you.